Hi everyone! Today we'll be presenting our poster analysis of the health system of France. So this is our poster, and without further ado, let's dive into the contextual factor in France. France's health system is shaped by several contextual pressures that will strongly influence future planning. Demographically, the population is rapidly aging, with projections indicating that by 2050, nearly 29% will be over 65 and 16% will be over 75. This demographic shift will increase the prevalence of chronic disease, with around 20% of older adults expected to have multiple conditions, therefore raising the demand for primary and long-term care. Hence, France's demographic shift has a high impact and long-term horizon on the map that you can see here on the right. Epidemiologically, France faces a high burden of non-communicable disease, which account for almost 79% of deaths. Therefore, in the positioning map on the right, this factor is placed in the high impact and long-term quadrant. The rise in NCDs reinforce the need for long-term strategic planning through public health intervention. Politically and legally, strong state involvement creates stability but also uncertainty when it comes to policy direction shift. In the dynamic mapping, both factors were plotted very centrally in terms of strength and time horizon. To add, the shortage of medical staff is partially due to very high entry requirement to study medicine in France. Economically, strikes and poor working conditions highlight systemic strain, while sociocultural disparities in health literacy persist. Hence, the economic environment acutely, which means short-term high-strength, impact the health system in France. Strikes are caused by complaints about low pay, overwhelming working conditions, and a shortage of staff. Emergency department recently experienced 6 months of strikes, and as a result, the system faced rising operational costs at a time when budgets are already low. Finally, ecological responsibilities and rapid technological innovation present both challenges and opportunities for future system resilience. France prides itself as a leading country in healthcare innovation. It's home to major global players such as Sanofi, Ipsen, Servier, with a turnover of 90 billion euros in 2023. Further large investment into hospital IT for infrastructure have been made and in an effort to upgrade the already outdated system.
France evaluates its care system performance against a clear set of national goals aligned with SDG 3, including promoting healthy lives, reducing health inequalities, strengthening the One Health approach, and addressing climate-related health challenges. These are supported by operational objectives such as expanding the healthcare workforce, reinforcing system-wide human resources, improving disease prevention across all ages, and enhancing preparedness for future public health emergencies. Across key performance indicators, France showed mixed results. Health outcomes are generally strong. Financial protection is also robust. This supports both horizontal equity, universal access through assurance maladie, and vertical equity, while vulnerable groups receive higher reimbursement rates. However, in comparative rankings, France's performance is below many European peers. Based on the CEO World Overall Healthcare Index, it places 25th globally, reflecting weaknesses in medical infrastructure, medicine availability, and government readiness.
France's health system combines strong public governance with a mix of public and private providers. Governance is split across three levels. 1. The Ministry of Health, who sets national policy. 2. The regional health agencies, which implement policies and coordinate services. And 3. The health insurance funds, who manage reimbursement and negotiate pricing and fees. The country has overall more providers and facilities than other EU countries. Patients choose their GPs and can self-refer to specialists, though reimbursement is better with a GP referral. Pharmaceutical prices and reimbursements are strongly regulated. Doctors are private professionals, but fees are still negotiated with the state. All these factors contribute to a high satisfaction level overall. Coverage is broad, including hospital care, GP and specialist visit, maternity care, prescriptions, diagnostics, physiotherapy, mental health, and preventive services. Patients usually pay up front but are reimbursed quickly, and those with chronic conditions receive 100% reimbursement.
Here I want to highlight three key issues in France's care system: how it is financed, how resources are allocated, and how providers are paid. First, although France looks highly public financed with Social Security and the national budget covering most spending, the system relies heavily on complementary private insurance. Around 96% of people buy extra insurance, shifting the real pressure into insurance premiums, which vary by income, age, and something else. As a result, low-income and older people end up paying a larger share of their income for even more limited coverage. So the system appears protective, but there is a hidden inequality. As complementary insurance expands, more insurance market logic enters the system. This may help with short-term budget pressure, but over time, it shifts fairness and sustainability risks from the public budget into insurance and families. Second, France allocates resources through a very top-down budget process. This diagram shows how France's funding flows are separated and make it hard for money to move across sectors. Each year, the Social Security financing law sets out spending targets and divides budgets into separate parts: hospitals, ambulatory care, and long-term care. This controls overall spending well, but it also makes it difficult to shift money. And national targets do not always reflect regional health needs. Some reforms, such as stronger regional health agencies, aim to improve this, but their impact so far remains limited. Finally, France uses a mixed provider payment model, but in practice, it is still dominated by accrual-based incentives. GP are manually paid fee-for-service, hospitals are paid by DRGs, and other providers also rely on volume-based payments. Quality or population-based payments exist, but they remain at a small percentage, so the core incentive is still the more you do, the more you earn, which encourages high service volumes rather than prevention, coordination, or chronic care management. In short, France must find a way to stay fair and sustainable while coping with more private insurance pressure, strict budgets, and incentives that still push providers to do more instead of doing better.
For the part of health service delivery in France, I'll begin with who provides care. As you can see from the left introduction, health services are delivered by various actors, such as self-employed, fee-for-service physicians, other health professionals, and so on. Overall, the system remains highly hospital-centered, and patients have full freedom in choosing their providers. The diagram on the right helps visualize how patients move across the system, and it also highlights why France's health system is considered fragmented. Primary, secondary, and long-term care operates through separate organizational and funding structures, so each stage largely functions on its own. Because gatekeeping is voluntary, links between sectors are weak, and primary care plays only a limited role in prevention. Recent reforms aim to improve coordination, but fragmentation remains a major challenge. In terms of quality, France performs strongly overall, with low mortality and high patient satisfaction. However, avoidable hospital admissions for chronic conditions remain higher compared with other countries, reflecting weakness in primary care and continuity of care. Finally, it is evidence-based practice. National clinical guidelines are formulated by HAS. Hospitals generally show high adoption because of certification requirements, while implementation in primary care is less consistent. So overall, France delivers high-quality care, but fragmentation and the limited role of primary care continue to be major barriers to achieving more integrated service delivery.
To conclude, we prepared some recommendations for the health system in France. Well, we recommend developing a national workforce redistribution strategy with the following measure. Increase the financial incentive for physicians in rural areas, including tax relief, higher salaries, and subsidized housing. We also want to offer a fast-track specialization program for young doctors that are willing to work in this region. We also aim to enhance infrastructure by creating multidisciplinary health centers with telemedicine and expanding local care network. Next, we propose reforming the complementary insurance system to make it more affordable for low-income groups and also the elderly. And by that we mean introducing an income-based cap on insurer charge, standardized benefit package for consistent coverage, create a public complementary insurance option for high-risk individual. Lastly, we suggest modernizing provider payment models to prioritize quality, and by that we mean increasing pay for quality incentive to about 10% of hospital and GP revenue. Implementing bundle payment for chronic disease treatment can be an option, and rewarding hospital for reducing avoidable admission and readmission is also a great thing. Thank you for listening.